allowed to. Did you tell Sanket to join?
Yes, sir. I have sent the link, sir.
But you should have told him. See, night at this time, they won't be doing anything. So it is important for people to take the understand the significance of attending all the classes. Somebody call him up and say if he's free to join.
Yes, sir.
Okay. Okay, start. See, last class we had actually discussed the some signs and symptoms of peripheral vascular disease. I think we will now go, because it is a vast topic. We decided that we'll split the management into a separate class. So now we are going to discuss the management of peripheral arterial disease. Okay.
Yes, sir.
Ravi.
Yes, sir. Good evening to everyone. As sir said, in the last class, I have seen about the clinical part. Today, mainly we'll be focusing on the management. Before going to management, I would briefly go once through the clinical part. Peripheral arterial disease can be defined as narrowing and obstruction of antegrade flow of major systemic arteries other than those of cerebral and coronary circulations. The etiology of peripheral artery disease can be classified into atherosclerosis disease. The risk factors for atherosclerosis disease are male gender usually, smoking, diabetes, hypertension, dyslipidemia, hypercoagulable states, and systemic inflammatory conditions. And other part is non-atherosclerotic disease. Non-atherosclerotic disease includes arteritis such as Takayuki, Buerger's disease, giant cell arthritis, aneurysm, and thromboembolism, aortic coarctation, and many other. And it is clinically graded by Fontaine's classification into grade 1 is asymptomatic, grade 2 intermittent claudication, grade 3 rest pain, and grade 4 ulceration or gangrene. The main investigations done for peripheral arterial disease includes Doppler ultrasound. Through Doppler ultrasound, it is will be quantitatively assessing the ABI, that is ankle brachial index. 0.9 to 1.4 of ankle brachial index is normal. Less than 0.9 signifies that there is hemodynamically significant arterial lesion. Less than 0.4 signifies that there is chronic limb-threatening ischemia. And if greater than 1.4, it indicates there is mediosclerosis and calcification of arterial wall. The next investigation is duplex Doppler ultrasound. In this, it uses B mode ultrasound to provide the images of the vessels, and it also shows color coding. It helps for the visualization of the blood flow and turbulence. Next is the distal subtraction percutaneous angiography. It involves injection of a radio-opaque dye into arterial artery, and the benefit is that it provides dynamic arterial flow. And the investigation of choice for peripheral arterial disease is the MR angiography.
No. I think see, the MR angiogram and CT angiogram are the investigations of choice initially to get a roadmap of the vessels.
Yes,
there
sir.
are disadvantages with both CT and MR, but with the improving technology, I think MR and CT angio are the investigations of choice. You keep the angiogram as a last choice when you are planning intervention. So you get a roadmap with distal subtraction angiography, with the CT or MR angiography, and then you do the angiogram, and then use the same procedure to intervene, radiological interventions, which we'll talk about.
Yes, sir.
Now you talked about the Fontaine system, and the other one is the Rutherford
Rutherford's.
classification.
Yes, sir.
But there is a new classification which helps to quantify the disease and manage the disease. And does anyone know of the new system? Which is not actually new, it's 10-year-old. Nikita,
No, sir.
Ainas,
So there was a void classification, but it doesn't quantify.
no, it's not void classification.
Void. Yes, I don't know that.
Vinod,
No,
you're
sir.
going. See, this is the advantage of reading the journals. You should read not just textbooks, but journals also.
Yes.
Sir, shall I tell, sir?
Huh.
Sir, wound ischemia foot infection classification, sir.
Correct. Wi-Fi
Yes, sir.
classification, which was brought in 2014. So
Yes.
what are the four thing is wound, ischemia, and foot infection.
Foot infection. Yes.
So in wound, it shows whether there is ulceration or gangrene.
Gangrene.
And with ischemia, it takes into consideration ankle brachial index, arterial blood pressure, and toe pressure.
ಅವ್ರೇನಾರು ನನ್ನ ಹೆಸರು ಹೇಳಿದಾಗ ನಾನು ಹತ್ರ ತಗೊಂಡ್ಬಿಟ್ಟು ರೆಕಾರ್ಡಿಂಗ್
And with foot infection, you look at whether there is infection or no infection, or if the infection is mild, moderate, or severe. So this gives you a much more objective evaluation of the disease so that you can plan the treatment. Other one is the global anatomic staging system, or GLASS. What is that? Does anyone know GLASS? Both of these classifications were ratified by the American Vascular and European Vascular Society. Does anyone know about the GLASS?
No, sir.
Global anatomic staging system. See, mostly this involves the lower limb. So basically it is the iotoiliac segment, femoropopliteal segment, or the below knee segment, or the tibiopopliteal segment. So based on the disease where it is, the interventions can be addressed to the different segments of the artery. And also the limb salvage and the avoidance of further vascular interventions and long-term results of the intervention. All of these they depend on the segment of the disease, that segment of the artery that is involved. So in combination with the Wi-Fi and the global anatomic staging system, or the GLASS, you can then plan the treatment. So these are two important things you should know about it. So all of you, homework is to go back and read and then put it up in the class. Okay?
Yes.
Okay.
Yes, sir.
Yes, sir.
Right. Continue.
Yes, sir. Coming to management, it can be non-surgical and surgical management.
And other thing you should know is, previously it used to be called critical limb ischemia. Now what is it called, Praveen? You have actually used it.
Yes, seems critical limb threatening ischemia, sir.
It is called, no, it's not critical, it's chronic limb threatening.
Chronic limb threatening ischemia, yes, sir.
So previously it used to be called critical limb ischemia.
Yes, sir.
So the classification is acute limb ischemia and chronic limb threatening ischemia. Okay.
Yes, sir. Coming to
Right.
non-surgical part, yes, sir. Coming to non-surgical part, we'll be treating the risk factors of smoking, exercise, hypertension, antiplatelets, and peripheral uses of peripheral vasodilators. We'll be going briefly about the smoking. Smoking usually increases the prevalence of peripheral artery disease to 2 to 3 folds, and the risk of incidence of PAD will be there still 30 years even after cessation. The mechanism of smoking interfering with peripheral arterial diseases, it causes increased endothelial cell permeability by formation of reactive oxygen species, which enables atherosclerosis. In a study, it showed that there was mortality of follow-up up to 5 years of 31% in patients with smoking versus 14% in non-smoking patients. And the amputation rate was about 40% in smoking patients along with PAD. When compared to non-smoking patient, it was only of 19%.
Wait. Go back. Nikita, here is said about the endothelial cell permeability. What are the other mechanism of action of smoking which causes peripheral vascular disease?
Sir, if there is any injury, it also impairs the healing process, sir.
Correct? I think it's not just endothelial cell permeability, endothelial cell damage. So it can cause damage also. That is one. Second, impaired healing, correct? Then what else?
And the vascular, the cell, I'm sorry, sir, the wall capacity to be elastic is reduced because of that. Can't put it in terms.
No, that is due to atherosclerosis. That's not specific to smoking. Once atherosclerosis happens, and then there is what is called as metastatic calcification
Yes,
of
sir.
the pathological calcification of the intima. That causes it reduces the compliance of the blood vessels. That is due to atherosclerosis. That can happen even with diabetes. But what is the other most important thing? Anyone? Sanya?
So is it the release of reactive oxygen causing endothelial damage?
That has already been mentioned.
Reactive oxygen species, yes, sir.
Reactive oxygen species.
That was one, sir.
Remodeling, sir.
Huh?
Tissue remodeling.
No, not tissue remodeling. Somebody
Release
said
of...
Huh?
No,
Somebody
sorry.
said vascular, but then didn't complete it. It causes vasospasm.
Spasm.
If you look at it, there will be initially this. No, even they have actually showed, even with one puff of smoke that somebody inhales, and then you look at the blood vessels, it goes into spasm. So, and then if it continues to do that, the vasospasm keeps on increasing. So that is another mechanism of damage. It reduces the blood flow because vessels go into state of chronic spasm. Okay, right, carry on.
It could be managed by both cognitive behavioral counseling, motivational interviewing, along with pharmacological therapy. It showed all these three therapies had showed a higher management in comparison with verbal advice alone. Pharmacological therapy, which includes varenicline, bupropion, and nicotine replacement therapy, which can be done in the form of gum, patch, lozenge, or spray.
Not lozenge, it's lozenge.
Lozenge. Yes.
Okay.
Coming to exercise therapy, it is recommended that thrice weekly supervised program of 30-minute walking sessions to near maximal pain for a period of at least 6 months showed a significant improvement. That is of around 150-meter increase in walking distance or 30 to 35% of increasing.
What does this tablet medicines help? What is the previous slide? How does this varenicline and bupropion mechanism of action?
Sir, it's a nicotine receptor partially connected nicotine receptor agonist, sir.
Oh, what is the dose? How long it should be taken?
Praveen, do you know?
Sir, no, sir. Dosage I don't.
Anybody else?
Sir, usually it differs from patient to patient, sir.
No, but I think again, this is homework for you. You should
Okay, sir.
find out which is effective and which is the usually used drug apart from nicotine replacement therapy. Okay.
Yes, sir.
Okay. Right. Carry on. Nikita,
Yes, sir.
tell us about what is this called? This set. What is set?
Sir, I didn't
Set.
get you, sir.
What is set? SET. You don't know?
No. I don't know.
It is common. It is standard. Why? I don't think you guys have read. Supervised exercise therapy. So tell me about supervised exercise therapy. How do you do it?
Sir, it should be
Why
at a
am I
particular
asking?
period.
Why they should be supervised?
Why am I asking this? It's probably the most important component of the best medical treatment.
Yes, sir.
How do you do it? And whom do you do it in?
There are specific exercises as prescribed by the physician, sir. So it will be done under monitoring of a physician or a physiotherapist. It will be
No, but
done most
first of all, tell me whom do you do it
in the patients who are diagnosed with peripheral arterial disease, sir.
No. See, that is a very stupid answer.
Symptomatic.
Vinod, whom do you
Just
do?
symptomatic does not require supervision.
CET in whom do you do it in?
Sir, in patients with intermittent claudications.
Patients with significant intermittent claudication. Nikita, can you do it in patients who have rest pain or tissue loss?
No, sir.
You can still do it in them. When do you do it in those people?
In case if you are providing any analgesic, sir.
No. How can you rest pain? People cannot walk, ma. That is why they have pain. They have pain even at rest. They won't be able to walk. So when will you then give them supervised exercise program? Think and answer.
After surgical intervention, later
After any intervention, whether it is surgical or
any intervention.
radiological intervention, where you have actually addressed the ischemic component by revascularization, then you can ask them to go on a supervised exercise program. Tell me about the exercise program. How do you do it? Does anyone know exactly how it is done?
No, sir.
You should first identify the distance of claudication. That is not what the patient says. You have to supervise the patient walking for how long he is able to walk and when does he start getting the pain, and then when does it start getting the pain which is unbearable and he has to stop. Patients do get pain, but they are able to walk through that pain. But then they get to a stage where the pain is so unbearable that they can't continue. So you have to identify both the distances, and then you start them, cessation of smoking, and then control of blood pressure, control of diabetes, good control of diabetes, and also vasodilators. You start all of these treatment and then supervise and ask the patient to walk through the pain barrier and carry on. In every day or every week, you increase the distance. Let us say the patient is getting claudication at 200 meters and the pain becomes very unbearable at 250 meters. You ask him to walk to 270 and that for a week, then maybe increase that to 300. So this is the supervision that you have to do. Why that is done is because unless you do it, the patients are not motivated enough to do this. So unless you do it under supervision, you will not know whether the treatment is working or not. Which is why you have to, and then you have the, because you are observing the patient, you can, if the patient has any other problems. What other issue with these people is that most people who have peripheral vascular disease will have coronary artery disease also. So they may have other problems, which is why you have to supervise these people. You don't want them to drop dead because you are giving them severe exercises. So that is why it has to be supervised. And what are the advantages of supervision and advantages of this exercise treatment, Nikita?
Advantages of supervision would be, as you have mentioned, motivation, at the same time monitored care, sir. If they
Monitor,
are,
yeah. And advantages of doing the exercise, how does it help?
it
See,
decreases
all of these patients will have what? They will have either narrowing of the vessels or complete blockage of vessels. Correct?
Yes, sir.
So what will happen if you exercise?
Collaterals develop.
Neovascular. Yes.
Neovascularization, collateral circulation will develop. So that is the advantage of doing this exercise. And how effective is this, Praveen?
Sir, there is around 30 to 35% of increase in the distance the patient was initially able to walk, sir.
So they have to continue the exercise. After you have supervised and realized how far they can walk, you can tell them they need to continue to increase the distance so that they will get the continued benefit of exercise therapy. Okay, carry on.
Along with the exercise therapy, it is supplemented with silastazole, which is an antiplatelet and also a vasodilator, and pentoxifylline, which is also a vasodilator. Along, it decreases the viscosity of blood. These two
No,
drugs are
pentoxifylline is
supplemented.
not a vasodilator. What is it called? Anybody? Pentoxifylline is not a vasodilator. Silastazole may be.
It also gives vasodilation, sir.
No,
As
the
a mechanism.
vasodilatation is minimal, but it is called hemorrheologic agent. What does that mean?
Prevents the aggregation of erythrocytes, sir.
Changes the flexibility of
correct.
erythrocytes.
It alters the blood flow pattern.
Viscosity of blood. Yes.
So by preventing platelet aggregation, streamlining the blood flow. So it is called hemorrheologic agent, pentoxifylline. There is another new drug. Does anyone know? Ticagrelor. Ticagrelor is another new drug that has been introduced, which is supposed to make the medical management better. So homework for you. What is it? How does it work? And the studies that show the improvement. All of you, okay?
Yes, sir.
TICAGRELOR, Ticagrelor. Okay?
I'll be
Right.
talking next about it, sir. Ticagrelor.
Okay.
Yes, sir.
Continue.
Yes, sir. Coming to lipid control, the elevated lipids and lipoproteins are associated with the increased risk of peripheral arterial disease. According to AHA recommendation, all patients with symptomatic PAD to be on high intensity statin, and individuals with PAD and another major atherosclerotic cardiovascular disease should be treated so that the low density lipoprotein C should be of less than 70 mm value. And another study by heart protection study collaborative group suggested that moderate intensity statin therapy major coronary events and 26% reduction in ischemic stroke. And this statin also reduced the rate of amputation with relative risk reductions between 18 and 35%.
Does anyone know, apart from reducing the cholesterol and triglycerides and the LDL and VLDL levels, how does statins work? What is the more important factor with statin in reducing the risk of coronary artery disease and also limb loss in peripheral vascular disease?
Inhibits ubiquitin, sir.
Huh?
Inhibits ubiquitin.
What does that cause? What does that do?
That
Inhibit
synthesis of cholesterol. Sir.
what?
Synthesis of
Speak.
cholesterol.
No,
Hello.
that cholesterol reducing, I've already told you.
Yes,
Lowering cholesterol levels is accepted level. This one. What is the added benefit? See, when there was a lot of the controversy about lipids and everything, they continue to use the statins. What is the reason for that?
Anticoagulant effect, sir.
No. Plaque stabilization effect. See, what happens is these cholesterol plaques, if they fracture, then it what shall we say, exposes the endothelium to the damage, and then there is platelet aggregation and then thrombus formation, which is then the cause for the occlusion of the vessel. So by preventing it stabilizes the plaque so that the fracture and those events are reduced, if not completely prevented, which is why it is very effective in both coronary and peripheral vascular disease. Okay, continue.
According to latest cholesterol guidelines, the usage of ezetimibe is useful in management of very high risk patients with LDL low density lipoprotein of greater than 70. And according to a 4-year trial, the usage of PCSK9 inhibitors, that is evolocumab, had showed a 59% reduction in LDLC and 3.5% of absolute risk reduction in cardiovascular events. And it showed a reduction of 42% in major adverse limb effects such as acute limb ischemia, major amputations. So the use of statins has a significant role in decreasing the adverse effects of peripheral artery disease. Coming to blood pressure, according to recent AHA guidelines, antihypertensive is recommended for the patients with cardiovascular disease and systolic pressure greater than 130 and diastolic pressure of greater than 80 mm of Hg. According to a study by Hope, it showed that the ramipril therapy in PAD led to 22% relative risk reduction, and the advised first line of therapy for PAD are AC inhibitors or angiotensin II receptor blockers. Coming to glycemic control, studies show that around 1% increase in HbA1c is associated with a 28% increase in PAD. And when PAD is associated with diabetes, it causes aggressive manifestation of the disease such as worsening of lower extremity function, sudden arterial thrombosis, and ischemic ulceration. And there is about 5 to 10 fold of increased chance of major lower limb amputation. So the glycemic goal should be individualized in patients with diabetes and keep the target of HbA1c of less than 7%. Coming to use of antiplatelets and anticoagulants, a meta-analysis showed that use of aspirin as a monotherapy had showed a reduction in stroke, but there was no statistically significant difference in major adverse cardiovascular events. And in another study by Kepri, which is clopidogrel as aspirin, it showed that there is which compared relative efficacy of clopidogrel with 75 mg and aspirin of 325 mg. Clopidogrel had a 23.8% relative risk reduction when compared to aspirin. And there was another study which showed that with the dual antiplatelet therapy, there was reduced restenosis and target revascularization after elective femoral-popliteal angioplasty. And this prolonged dual antitherapy of greater than 6 months should be considered after revascularization with the patients who have high risk of restenosis. In another study by Euclid, that is use of ticagrelor, it showed that there is in the symptomatic PID, when ticagrelor of 90 mg is given twice daily, and between clopidogrel, there was significant increase, but there was no difference between the two groups. Ticagrelor is a P2Y12 inhibitors, which acts as antiplatelet aggregating agent. And in another study by Weiger, it has studied the rivaroxaban 2.5 mg twice daily. In patients of high risk and when there is bleeding is of less concern, rivaroxaban can be given of low dose along with aspirin. These are the various
What are the
studies
standard
showing
medicines now given? Tell me.
Sir,
For each
the
for each
standard
stage.
is first. Sir, clopidogrel is the first preference, sir. Monotherapy. In patients with high risk patients, and if there is chance of restenosis, then dual therapy of clopidogrel along with aspirin is suggested, sir, advised.
Though I think what what Praveen said is right. Usually the standard treatment is the combination therapy with aspirin and
Yeah, that's what I was asking.
clopidogrel in patients who have difficult.
Because in exams they will ask you usually what are the standard treatment given.
Patients with severe upper GI symptoms, you can stick to only clopidogrel as opposed to aspirin with clopidogrel. There is in very high risk individuals, triple therapy with the clopidogrel, aspirin, and rivaroxaban is, and patients, as he said very rightly, who have less chance of cerebrovascular and other bleeds. In such patients, rivaroxaban can be added. So that is the standard treatment. Understood?
Yes, sir.
Okay, continue.
Coming to other drugs.
What does it take, rivaroxaban?
Sir?
Rivaroxaban, how does it act?
Factor 10A inhibitors.
Sir, 10.
Anticoagulant.
It is actually the
Yes, sir.
now considered the anticoagulant of choice because of the mechanism of action, and there is no need for regular monitoring. Because you can safely give it if the patient tolerates it. The effect is very good, especially for patients with, let us say, deep vein thrombosis, pulmonary embolism. Such patients and patients who have, this one, protein C, protein S deficiency, all of these who have high, incidence of coagulation pathology. Such people, rivaroxaban, there are others also, but rivaroxaban advantage is that you don't need to monitor PT, INR, or APTT or anything like that. Continue, ma'am.
Recently, they have been introduced prostanoids, which is an PGA1 and PGI2 prostaglandins, which can be used parenterally. The mechanism of action is it inhibits the platelet aggregation and leukocyte activation along with vasodilator effect. These are mainly used in the critical ischemia patients, and this is a new drug recently introduced. Coming to the surgical management, patients who are requiring surgery is patients with advanced stages of ischemia, that is third and fourth, requires a surgery. And this is the table showing the sector affected and the stage of the patient who is requiring the surgery. In 2B, patients with iliac sector affected and along with femoropopliteal first portion, they requires surgical management along with grade 3 and grade 4. It can be managed by transluminal angioplasty and stenting. Here, we'll be inserting a balloon catheter into the artery and we'll be inflating it within a stenosed or occluded segment. And here you can see the balloon catheter. If this balloon catheter, if this vessel fails to stay adequately with this balloon catheter, then we can use a metallic stent to hold the lumen. And these are the metallic stent. Coming to the procedure, endarterectomy, it is the direct removal of obstructive plaque from an arterial segment. Most commonly, the endarterectomy will be used in the femoral sector involvement. And the limitation is there is adequate secure of endpoints cannot be done. And there is high chance of thrombogenicity due to raw surface area, which can causes recurrent stenosis. The next mode of management is bypass.
You're not, there are lots of things that you need to cover. What are the latest things that you know about the balloons? And what is the trial that is being done to show whether it is surgery or the endoluminal procedures which are better? What are the, has anyone read anything new about the balloons and the stents that are used? Sania?
So the recent one I had read was the SEM stent, was a self-eluding metallic stent. But
what is the drug that is used? So drug-eluting stents.
One second. So that
See I think all of you please listen carefully. I think you have not. I think none of you have actually made an effort to read the latest journals. You just read from textbooks. See there are many types of balloons. What is called cutting balloons, cryoplasty balloons, focal pressure balloons, and drug coated balloons, and chocolate percutaneous PTA balloons. So these things are all either what is called as bare metal stents, or you have coated stents also. Basically, the balloons that are used for angioplasty, these cutting balloons will have ability to cut through the stenosis. They are made of tougher material, so the balloon rupture rates are less. Cryoplasty uses nitric oxide along with the balloon, so that in the usage of the cryo therapy will help to improve dilate the vessel, in addition to taking care of the plaque. Focal pressure balloons, which have higher focal pressure, so that with arterial disease with severe calcium deposition can be taken care of. And then the drug coated balloons are the ones, stents, which are used, which elute paclitaxel, which is the chemotherapeutic agent that is used, taxanes that are used for breast cancer, or the new ones is called sirolimus, which is a monoclonal antibody similar to tacrolimus. So these two drug-eluting stents, though they have better revascularization procedure, long-term mortality in these patients were seen. But FDA was brought to notice about this, but still it has given permission for this to continue. So for the time being, these drug-eluting stents are being used. These were as an extension of what they used for coronary stents. Okay, then there are newer procedures called atherectomy or atherectomy. What you said about endarterectomy can also be done percutaneously. That is directional. So the atherectomy, this one, it rotates in a particular direction and cuts through the calcium and the plaques. Then there are rotational ones where it rotates at very great speeds. The advantage of these things is that what they do is they have a distal protection. So they will block the distal circulation so that the plaque that is dislodged doesn't go into the distal circulation and block it. And then you use rotational device. And then there is something called orbital device, which is similar to rotational device, and laser. Laser, they use excimer laser. So all of these things are used to do endarterectomy by the minimally invasive method, not by doing endarterectomy by operation method. Then there was this question whether they should do this or they should do surgical endarterectomy or any surgical procedure. So they conducted a trial called the Best Fly trial. So the Best Fly trial results came out in 2023, which they included 1,830 patients, and this was I think all of you should go up and read New England Journal of Medicine. And the best, it is called BEST-CLI trial. So this showed that 1,830 patients and results of 2.7 years of follow-up. This one was in cohort 1 when patients had good saphenous vein. In cohort 2, if they did not have good saphenous vein. So if they had good saphenous vein, the major limb reintervention amputation rates were 42.6% in these patients. Among that is about 900 and odd patients, and as opposed to 58% in patients who had no greater saphenous vein. So which means even now surgical intervention with saphenous vein graft, whether it is for femoropopliteal or femoral distal graft, is better compared to any of these interventions in the form of angioplasty plus stent insertion. So, and if you look at the reamputation rate or amputation rate and revascularization and reintervention rates, it is significantly, it was statistically significant. So that means as of now, surgical intervention is better than radiological intervention, percutaneous interventions, even though the radiological technology is advancing and improving rapidly. As of now, still surgery is better compared to any of this radiological intervention. But obviously, you have to look at the patient's general condition, diabetic status, his cardiac status, and all of these things. If the patient is unfit, then at least you can do radiological intervention, which has a lesser success rate, but then probably less complication rates also. Okay, now talk about this endarterectomy.
Sir, I said will be it is the direct removal of obstructive plaque from the arterial segment, and it's the high success rate is seen in the femoral segment endarterectomy. The limitations will be there is inadequate securing of endpoints, and there is high chance of thrombus formation as there is low flow environments and raw area, which leads to recurrent stenosis of the artery.
No, but what do you do to prevent recurrent stenosis? Nikita, they have shown something there.
Metallic stunting, sir.
No, not stenting.
In
If
this
you have opened the artery, surgical arteriotomy and endarterectomy.
a patch would be made, sir.
What patch?
Miller's patch, sir.
See, the thing is, you can use a small vein, so vein patch. So don't try to harvest the saphenous vein because you may need it for bypass. If you are just doing endarterectomy, don't disturb the saphenous vein, because saphenous vein will probably, in case later if you want to do a bypass graft, you may want to use it, or even for example, for cardiac, you may need the saphenous vein. So you can use as any vein and put it as a patch, or if you don't have a vein, you can use a PTFE patch. What Praveen said is, if at all, see, first thing you have to do is, after you have done an endarterectomy, you have to internally use 70 sutures to stabilize the the intima and the endothelium. So wherever there is, you can see that the intima is getting lifted up. You put sutures there, 70 sutures, 7 or 80, to sort of stabilize the intima, and then you put a patch, usually using PTFE, that is polytetrafluoroethylene, or what is that called? PTFE.
PTFs.
Teflon, sir.
Gore-Tex. Gore-Tex. It's a Gore-Tex. This one. You get it as, you can get small segments of Gore-Tex. It comes as, PTFE is another material that is used for, you get grafts also. Teflon is one, that is, Dacron or Teflon, and Gore-Tex. So you usually, Dacron you use for, for grafts, but you use PTFE for patches. Or you can use a vein for patch. So the advantage of that is it prevent restenosis to some extent. Okay, carry on.
Yes, yes. Coming to the bypass method, the main characters required for a bypass grafting is there should be unobstructed inflow, good quality of conduit, and adequate outflow. An ideal bypass should have an antithrombotic endothelial surface, and it should be it should have similar physiological and mechanical properties of native arterial one, and it should have resistance to infection and resistance to inflammatory changes that resulting in stenosis or occlusion. As close to the ideal bypass, we can have the similar materials are Dacron and polytetrafluoroethylene. Recently, there is collagen or gelatin impregnated Dacron PTFE materials. The advantage is it has long-term structural integrity, and it has increased inability to incorporate into the native tissues. But the limitation of this Dacron or PTFE grafts are it has potential for infection, and there is a chance for thrombosis. Coming to individual bypass, we'll be seeing the iatrofemoral bypass. It is bifurcated prosthetic graft from infrarenal abdominal aorta to each common femoral arteries. The 5-year patency rates is about 90%, and 10-year patency rates it's about 85%. Here you can see two types, end-to-end and end-to-side. In end-to-end, it is usually preferred method which has non-turbulent flow. In end-to-side, the problem is the anastomosis requires longer segment of disease-free aorta. And most common cause of failure of this iatrofemoral bypass graft is there is progression of atherosclerosis happens in femoral artery, and there is chance of neointimal hyperplasia at distal anastomosis site.
Is end to side or side to side?
Sir?
End to side or side to side?
In end to side, sir.
End of what?
Sir, end to side, sir.
Where is the end, man? See?
Sir.
No, in diagram B has shown the end of the aorta.
This is B.
Yeah, by end to side. That B is end to side.
Yes, sir.
B is end to side. And
B.
C is side to side.
Correct. C is side to side.
Sir, based on grafts, will be telling us, sir.
Carry on.
And the late complication of iatrofemoral bypass can be pseudoaneurysm formation.
See, what
Here
is
you can see
anybody, what is the commonest cause for occlusion of these grafts? Anybody? Nikita? Ainaz, you are very quiet.
Could be like because of inflammatory changes which causes.
No, not inflammatory changes, ma'am. Anybody? The most common cause for graft failure or graft occlusion is distal disease. See, even though there is a good pressure head, if it has got nowhere to go, then obviously the flow will slow down and ultimately it will come to a stop. So
Progressive disease.
progression of distal disease is the most common cause for the. So you have to ensure that even after surgery, stopping smoking, control of lipid and this one exercise, hypertension, diabetes, all these things are very important. So the role of surgery is in addition to best medical therapy. Otherwise, these grafts are bound to fail. Okay, continue.
Next is extra anatomic bypass. It enables revascularization of limbs via non-anatomic pathways. The indications are when there is uncorrectable coronary artery disease, poor ventricular function, advanced pulmonary disease, renal failure. That is all the high-risk patients. And if patient has multiple reoperations, pre-radiotherapy and active infection. It is of two types, axillo-unifemoral or axillo-bifemoral bypass. And other type is femoral bypass. Axillo-femoral bypass is usually these bypasses are done via subcutaneous tunnel. Axillofemoral bypass is done at lateral region of thorax and usually right axillary artery is used. Femoral bypass is done through suprapubic region.
Is saphenous vein is used or graft is used for this?
Sir, graft is this is axillary artery is used, sir, in axillo-unifemoral.
No, but see, what is the commonest cause for axillofemoral bypass?
Sir, I did not get you, sir.
What is the commonest indication for axillofemoral bypass apart from what you have said?
Sir, usually this is done in patient with
Where
chronic
aorta cannot be
limb
used?
ischemia, sir.
Where? Which condition?
Yes. In coronary artery disease patients.
Why can't aorta be used in the coronary artery patients? See, if there is anybody, Nikita, Sanya,
Aortic aneurysm or if any aortic other disorders, sir?
aortic aneurysm, you do aneurysm repair. Why do you have to do axillobifemoral? Graft infection. So whenever there is graft infection, the patient is in very bad. You can't obviously, as Srikanth said, you can't use if the aorta you already done a graft or you have done a aorta-ilia graft, and if there is infection, obviously then you can't use that. So then what you would have to do is to do a extra anatomic bypass, which is usually axillobifemoral or axillofemoral, depending on whether the ischemia is on one side or both sides.
Yes.
Okay, carry on.
And it has low patency rates when compared to other bypasses, that is of 40 to 70% at 5-year follow.
What is the advantage of doing this one, the extra anatomic bypass?
Sir, actually it is a quick procedure and many studies said that it can be done in local regional anesthesia. So
yeah, that's one thing. And second,
sir,
if it remains patent for a reasonable period of time, it will allow collateral circulation to form. So hopefully, reducing the dependency on the graft itself.
yes, sir.
Okay.
Coming to femoropopliteal bypass, usually the great saphenous vein is preferred conduit for the femoropopliteal, but around 40% of population doesn't have ipsilateral saphenous vein. So in those population, contralateral great saphenous vein is used. And post-operatively, the usual complication is of lower extremity edema. This is because due to anatomic dysfunction from chronic ischemia and due to inflammation and interruption of lymphatics from during the surgical procedure. Usually it can be managed with limb elevation itself. And
What
the
is the
early
first?
graft failure.
What is the first? What shall we say? Precaution you need to take before you use the saphenous vein for graft. Vinod?
Sir, deep venous system should be patent.
Okay, that is a smaller. That is also important, but more than that.
DVT.
So that is what is a DVT. If the deep vein system is patent or not. Yes, DVT is there or not. Yes, you have to identify that. That more than that, what else? What else you have to do? Nikita, you are not thinking. None of you are thinking. You are just all of you are sat in the class without actually preparation.
Sir,
You have to,
other evaluation should be done, sir.
what other evaluation?
Coronary system is any
Correct. See, you have to ensure that the coronary circulation is intact, or there is no, disease that needs to be treated. Because if it is the case, obviously now you have the two internal mammary arteries, and also there is significant portion of the coronary artery disease is treated by coronary stenting. So not so much nowadays, but still it is important that you assess the cardiac disease, because straight away you will know whether the disease is stentable or does it need bypass grafting. So if it is stentable, then it's fine. If it needs bypass grafting, then you need to see how many vessels, whether it's a 2-vessel bypass, 3-vessel, 4-vessel bypass. If it is 2-vessel, then again you can use the right and left internal mammary arteries. So you don't need the saphenous vein. If it is a 4-vessel, then obviously you need the saphenous vein. So then you have to ensure that one limb, at least a saphenous vein, a good saphenous vein is left for the coronary disease. So these are all the evaluations you have to do before you harvest the saphenous vein for the. So how has anyone seen grafting done? So the femoropopliteal bypass graft done in continuity, or you have to dissect the saphenous vein and take it out? So what is it called? Maybe not.
So valvotomy.
No, what is it called? When you harvest the saphenous vein and then use it for bypass, what is it called?
No, sir. No idea. Sir.
Reverse saphenous vein graftment.
Yes. Sir.
You have to reverse it.
Yes, sir. Yes.
Why do you reverse it?
To prevent valves.
The valves will be there, so they will prevent the flow. Other thing is the larger end will go to the distal anastomosis. So you have a fairly wide distal anastomosis. So the anastomotic stenosis and narrowing is much more common at the distal end than the femoral or the proximal end. So you reverse the saphenous vein for two reasons. If you do it in continuity, what do you do?
Valvotomy.
You have to you have a camera now you have available. So under vision, you pass this one camera and identify all the valves and destroy it. Then you can use it in continuity. Okay, right. Carry on.
Yes. And the early graft failure is seen only in 5% of the total bypass procedures, and it is mainly due to result of technical errors. Hence, the patency is about 90 to 95%, that is well maintained in the femoropopliteal bypass graft using the saphenous vein. And these are the expected 5-year patency rates seen in suprainguinal bypass graft, that is all the iliofemoral, and iliofemoral and iliofemoral bypasses showing 80 to 95% of 5-year patency, while the extra anastomotic bypasses shows around 55 to 85% patency. And in the infrainguinal revascularization, femoral endarterectomy, which was said earlier, it has 90% of 5-year patency. And Next, which is femoropopliteal bypass with the saphenous vein shows around 70 to 75%. And all the small and medium-sized vessels vascularization has less patency rates, that is of around 40 to 60%.
So if
When
you are doing
all
a
these methods,
femorodistal bypass, if you don't have a saphenous vein, what do you do?
sir, we can use the Dacron and PTFE graft, sir.
Usually it is PTFE. So
Yes, sir.
to improve the patencies, what do you do?
Sir.
You create something called a boot or a wolfie. The wolf was a vascular surgeon in St. Mary's. So professor of vascular surgery, he devised a boot which is made of one of the veins that you can harvest locally, and you make an arteriotomy and then stitch the vein in the form of a boot, and then lay the graft onto that, so that this neointimal thickening, which usually happens, which causes graft occlusion, rates of neointimal thickening will be reduced. So the patency is increased by 20 to 30%. If you don't have a saphenous vein, use the PTFE or Dacron graft, and then use a boot to stitch it to the distal arteriotomy, and then place the graft onto the boot.
Axillary vein be used.
You can use upper limb veins. Yeah.
Why saphenous vein is preferred over axillary vein?
Anybody?
Sir, wide.
Not
Easy
just
accessibility, sir.
easy accessibility, and then
Has a deep vein system to
length, man. I think that is the most
Length.
important, because it is a long, the entire lower limb, you get a long length. So that is the main reason for using saphenous vein.
Morbidity is less.
Because the deep system is there.
Yes.
Okay, continue.
What is this pedal bypass?
Sir, in the distal arteries occlusion, sir, we'll be using this.
From where to where anastomosis? Man, 10 o'clock.
Sir.
So post it in the WhatsApp group. Don't know.
Yes, yes.
Okay, carry on, man.
Yes, sir. And if all these
Amputation you can do in another class, man.
Are you talking? How many slides have left?
no, sir, this last slide, sir. Just briefly about amputation.
No, amputation you don't have to touch. See the.
Okay, sir.
See,
amputation only you can have a separate class, man.
Separate class, of course. So the other things that have all come recently is what is called as retrograde access. See, the access to the vessel is antegrade usually. Now they are using something called retrograde access, which will help to improve the efficiency of the placement of stents. See, stents, as I was referring to, are mainly stainless steel, and nowadays we have nitinol stents, self-expanding stents. So nitinol tungsten, that is nickel titanium alloy stent. So that is self-expanding stent, and then along with that you have self-expanding stent which is coated also, and covered stents. Covered stents have a better patency rates compared to the what we call as the bare stents, which is just stent put onto the vessel. But the stents that are covered with PTFE will have a better patency rates, and the ones which are drug eluting will also have better patency rates. And there are the 5 new techniques have happened. One is the pedal intervention. So you add, in addition to doing the stent, you do a pedal intervention, which will improve the long-term survival of these stents. Other things are, as I said, the special balloons that are available, which will make your placement of stent and also endarterectomies better. And in patients who have chronic total occlusion, you have new devices which will, overcome the occlusion, so that you can improve the patency of the graft. And then you have newer methods of thrombectomy, thrombolysis, and new filters that are there, which will prevent these, the plaques that are dislodged, which, going down distally and then blocking the vessels. So there are lots of advantages, newer techniques, newer, improvisations, which have come. And I'm sure the from now on, though as of now, the latest trial shows that surgery is still the better, option in terms of long-term survival, long-term, patency, and long-term less reinterventions and, amputations and other procedures. I think the endovascular stents, endovascular procedures will continue to improve, and especially in patients who are of higher risk, they will be the procedures of choice compared to open operations. So I think that probably will summarize the procedures for the peripheral vascular disease. Srikanth, your final comments?
Very good presentation and discussion. Excellent.
Sania, Nikita, Ainaz?
Yes, good presentation, sir. Discussed a lot of both medical as well as surgical management.
Too much for surgeon.
Yes, sir.
I think,
vascular surgeons don't teach so much operation and investor.
my own, this one is, Praveen, you have done a reasonable job as far as the established techniques are concerned. But I think there is a sincere lack of, as we keep on saying, you need to look at journal articles to get to know what is the latest. For example, I think you should have all known about this best CLI trial, which reported in 2022-23. So all of you, please read up about the best CLI trial. And I think all of you have to, inculcate the habit of reading journals and also critically appraising them, so that you know what is there in the realms of the modern surgery. I think that is very important. I'm sorry that you didn't do all of that, but whatever homework I have given you, you have to religiously do it. Otherwise, there is no point in having classes. Praveen, well done, but you need to improve. Newer literature, needs to be looked at. Okay. Good night.
Yes, sir. Thank you, sir.